Welcome. In the previous session we discussed the infective lesions of the eyelid, the inflammatory lesions of the eyelid, the benign tumors arising from the epidermis of the eyelid skin, as well as the benign tumors from the sebaceous glands of the eyelid skin. In the second and concluding portion of the topic, we will be discussing the remainder of the lesions falling under the terminology benign eyelid lesions. But as we have discussed in the previous session, many of the lesions appear similar clinically and can only be distinguished histopathologically. We start with benign tumors originating from eccrine sweat glands, and we have discussed in the previous session that there are two types of sweat glands, apocrine and eccrine. Eccrine hidrocystomas are also known as pseudodiferous or sweat gland cysts, and they appear as multiple small cystic lesions clustering on the lower eyelid and near the medial canthi. Being cystic, they are usually translucent with an overlying smooth, shiny skin. They tend to enlarge during heat and increased humidity, and on histopathology, eccrine hidrocystoma appear as a dermal cyst lined with double-layered cuboidal epithelium without papillary infoldings. Papillary infoldings, as we will see, are found in apocrine hidrocystomas. Syringomas are also benign eccrine sweat gland tumors, and they appear as multiple small waxy nodules occurring on the lower eyelid as seen here, and they are commonly found in pubertal females. On histopathology, syringomas appear as intraepidermal ducts lined with double-layered cuboidal epithelium embedded in a dense fibrous stroma. The lumen of the duct can taper due to proliferation of the lining cells, resulting in a tadpole-like configuration. Chondroid syringoma or pleomorphic adenomas of eccrine sweat glands occur in middle-aged males, and they are rare and occur as solitary tumors. On histopathology, sweat gland ducts are found lined with the typical inner secretory and outer myoepithelial cells in a cartilaginous stroma, similar to pleomorphic adenoma of salivary and lacrimal glands, which also show a mixed pattern of glandular and fibrocartilaginous tissue on histopathology. Malignant change is known to occur in chondroid syringomas. Apocrine hidrocystomas or cyst adenomas arise from glands of mole near the eyelid margin. They occur as solitary translucent cysts which transilluminates, and they may extend deep in the canthal region and do not increase in size in hot weather. They are considered proliferative in nature, unlike eccrine hidrocystomas, which are considered as retention cysts. On histopathology, apocrine hydrocystomas show a dermal cyst lined with inner secretory and outer myoepithelial cells with papillary infoldings. This is the cavity of the cyst showing papillary infoldings of the lining wall. So in contrast to eccrine hidrocystomas, apocrine hydrocystomas are solitary, transilluminate, do not increase in size in hot weather, and show papillary infoldings of the cyst wall on histopathology. Syringomas are uncommon tumors and appear as smooth, dome-shaped, flesh-colored nodule. They may be dominantly inherited, and on histopathology, syringomas show islands with pale staining central cells and peripheral small basal cells. When numerous syringomas occur on the scalp, it is called a turban tumor. Benign tumors originating from hair follicles are uncommon. Trichoepithelioma are small flesh-colored firm papules with occasional telangiectasia and occurring over eyelids. So here we see a patient with multiple trichoepithelioma which are flesh-colored. They occur in older individuals and rarely ulcerate. On histopathology, syringoma appear as cysts filled with keratin and lined with peripheral basaloid cells, sometimes with immature hair follicles within the cyst, and they can be confused on histopathology with basal cell carcinoma. Trichofolliculoma appear as solitary, flesh-colored nodule as seen here in this picture, and they are usually umbilicated because of the opening of a keratin-filled hair follicle, and small white hairs protruding from this opening actually suggests the diagnosis of trichofolliculoma. They occur in adults And on histopathology, Trichofolliculoma shows a dilated follicle lined by stratified squamous epithelium continuous with the epidermis and containing keratin and hair shafts. So in this picture, this is the inside of the hair follicle, which is lined by stratified squamous epithelium and containing keratin and hair shafts. Trichilemmoma also appear as a solitary flesh-colored nodular or papillomatous nodule, and they usually occur in adults. And on histopathology, we find lobules of glycogen-filled cells with peripheral palisading and a distinct membrane around hair follicles. So in this picture, this is the central hair follicle, and we find lobules of glycogen-filled cells, and these lobules have peripheral palisading with basalloid cells with distinct basement membranes. Multiple trichilemmomas occur in Cowden's disease, which is an autosomal dominant condition with multiple hamartomas. And patients with Cowden's disease have increased risk of breast and thyroid cancer. Pilomatrixoma, also called Pilomatricoma or calcifying epithelioma of Malherbe, occurs in children and young adults. In the periocular region, they occur in the eyebrow or in the central upper eyelid, and they appear as very firm, reddish subcutaneous nodule attached to the overlying skin but mobile over the underlying tissue, and they can become relatively large. And chalky white deposits can be seen within the tumor. On histopathology, Pilomatrixoma show islands of basophilic epithelial cells which transform into central shadow cells, which are often calcified, and Pilomatrixoma can be associated with systemic entities such as Gardner syndrome, familial adenomatous polyposis, myotonic dystrophy, Turner syndrome, and Rubinstein-Tebbe syndrome. Among benign tumors of vascular origin, we have discussed capillary hemangioma, lymphangioma, and nevus flammeus in the session on orbital tumors of vascular origin. And here we are going to discuss pyogenic granuloma only. Pyogenic granuloma is the most common vascular lesion of eyelids, and the name is a misnomer because it is neither pyogenic nor granulomatous. Pyogenic granuloma occurs following trauma, surgery, and inflammatory lesions, and it appears as a fast-growing, fleshy, red to pink pedunculated mass which readily bleeds on contact. On histopathology, we find fibrovascular granulation tissue with acute and/or chronic non-granulomatous inflammatory cells. Neurofibroma we have discussed in the session on benign orbital tumors of neural origin. Xanthomatous lesions are characterized by the presence of foamy histiocytes with intracytoplasmic lipids, and Xanthelasma is a common finding consisting of a soft yellowish plaque on the medial aspects of the upper and lower eyelids, and it consists of foamy histiocytes in the superficial dermis. 50% of patients with Xanthelasma have associated hyperlipidemia, most commonly type 2A. Patients with Xanthelasma should undergo assay of serum lipid levels, and for cosmetic reasons, Xanthelasma can be removed by excision, laser ablation, or application of topical trichloroacetic acid. But following removal, Xanthelasma commonly recurs. Juvenile xanthogranuloma, JXG, or nevoxanthoendothelioma occurs before 2 years of age. Clinical features of JXG include skin lesions and ocular lesions. The skin lesions occur in the head and neck regions, and they appear as orange, red, or brownish nodules. They initially increase in number as well as size and then regress, leaving atrophic scars. Intraocular lesions of JXG include localized or diffused vascular lesions of the iris, which rarely regress spontaneously, unlike the skin lesions of JXG, and complications such as hyphema, uveitis, and glaucoma are common and can lead to phthisis. And since intraocular lesions of JXG do not regress spontaneously, they require treatment with topical or subconjunctival steroids. For diagnosis, skin biopsy is done for both skin lesions as well as suspected iris lesions, and biopsy shows foamy histiocytes as well as Tauton giant cells. Benign lesions of melanocytic origin are varied, and melanocytic lesions arise from cells producing pigments, and not all pigmented lesions are melanocytic. Also, not all melanocytic lesions are pigmented. And these cells include epidermal or dendritic melanocytes situated between the basal cells of the epidermis, the dermal or the fusiform melanocytes situated in the dermis, the nevus cells, which are considered a variant of melanocytes or immature melanocytes, appear larger, lack dendrites, and occur in nests in the epidermis. Melanocytes originate from neural crest cells, and racial pigmentation and tanning occurs when melanin produced by the epidermal melanocytes are transferred to the surrounding epidermal cells. Nevi are benign tumors arising from nevus cells, and they are commonly found in fair-skinned individuals. They are not found at birth, this is important to remember, and they appear during childhood and become more pigmented at puberty. In the evolution of a nevus, 3 stages are described. In the junctional stage, the nevus cells are found in the basal epidermis near the dermal epidermal junction, and the junctional stage is found in children and appear as a flat pigmented macule, and this macule gradually increases in radial size with the growth of the child. In the compound stage, the nevus cells are found both in the epidermis and dermis, and they appear as a slightly elevated pigmented papule, which no longer increases in radial size. So when the nevus starts to show elevation, it no longer increases in radial size. And almost all junctional nevi which occur in children become compound after the second decade of life. In the dermal stage, the epidermal component of the compound nevus atrophies and the dermal component persists. So in the dermal stage, the nevus appears as an elevated papule which gradually loses pigmentation. Nevi can occur in the eyelid margin, where they typically mold to the ocular surface, and this is a very characteristic feature of nevi as we see in this picture. Most nevi are asymptomatic, however some may irritate the ocular surface or obstruct the visual axis or block the lacrimal drainage. Rarely, a junctional or compound nevus can undergo malignant transformation suggested by irregular growth of the lesion, and nevi can be removed by shave excision or wedge resection. Congenital melanocytic nevi are found in 1% of newborns. Unlike that of simple nevi, they appear as single or multiple dark colored lesions having irregular borders. The surface may contain hairs as we see here, and kissing nevus consist of congenital melanocytic nevi occurring in adjacent areas of the upper and lower eyelids. This arises from a nevus developing before the eyelids separate. Histopathologically, congenital melanocytic nevi resembles compound nevus arising from nevus cells, and they have a 5% risk of malignant transformation, with the risk of malignant transformation being higher for larger lesions. The malignant transformation usually occurs in the dermal component of the lesion and so is difficult to detect early. Excision of congenital melanocytic nevi is recommended, at least the larger ones. Ephelis or freckle are flat pigmented macules occurring in sun-exposed areas in fair-skinned individuals, and they constitute increased melanin production by epidermal melanocytes without an increase in the number of the epidermal melanocytes. Ephelis can darken with sunlight exposure. Lentigo simplex are flat, uniformly pigmented macules. Being flat with uniform pigmentation are characteristics of Lentigo simplex. They represent increased production of melanin by epidermal melanocytes, as well as an increase in number of epidermal melanocytes along the basal layer of the epidermis. So they resemble junctional nevi but are composed of epidermal melanocytes and not nevus cells. They are usually found in childhood and can occur in any age, and they are not related to sun exposure and does not darken with sun exposure. Multiple Lentigo simplex lesions may be associated with Poitz-Jeghers syndrome, in which gastrointestinal polyps can occur with a potential to undergo malignant transformation. Solar lentigo occurs in older individuals but can occur in the first decade of life in xeroderma pigmentosum. Unlike lentigo simplex, it occurs in sun-exposed areas of the skin such as the forehead and dorsum of hands. Like lentigo simplex, it appears flat and uniformly pigmented and occurs in clusters as seen in this picture. And like lentigo simplex, It represents increased production of melanin by epidermal melanocytes along with increase in the number of epidermal melanocytes. Lentigo maligna or Hutchinson melanotic freckle is a pre-malignant lesion and is flat. But unlike Lentigo simplex and solar lentigo, it is irregularly pigmented with irregular borders and progressive growth. So these characteristics differentiate Lentigo maligna from Lentigo simplex and solar lentigo, being irregularly pigmented as seen here with irregular borders also seen here and having progressive growth. Lentigo maligna occurs in older fair-skinned individuals and can extend to the conjunctiva when it appears like a primary acquired melanosis. On histopathological examination, Lentigo maligna shows diffuse hyperplasia of atypical melanocytes in the basal layer of the epidermis, and the histologic abnormality extends beyond clinically visible margins. The risk of conversion to Lentigo maligna melanoma, which we will be discussing in the next session, is 2 to 6%, and Lentigo maligna should be excised with adequate margins, followed by close monitoring for recurrence. Blue nevus appears as dark blue-gray or blue-black slightly elevated lesion. They are less than 10 mm in diameter. They are either congenital or developed during childhood, and they represent proliferation of dendritic or epidermal type of melanocytes in the dermis, as we see here. So blue nevus, although called nevus, do not arise from nevus cells but arise from melanocytes. Cellular blue nevus are larger than blue nevus, and they contain pale spindle cells in addition to dendritic melanocytes within the dermis, and cellular blue nevus has potential to undergo malignant transformation. Dermal or oculodermal melanocytosis are diffuse blue nevus occurring along the distribution of the first and or the second division of the trigeminal nerve. When restricted to the territory of the first division of the trigeminal nerve, it is called nevus of Ota, and when restricted to the territory of the second division of the trigeminal nerve, it is called nevus of Ito. In this patient, territories of both the first and the second divisions of the trigeminal nerve are affected. Dermal or oculodermal melanocytosis appears since birth, and unlike most other pigmented lesions, it usually occurs in dark complexioned individuals, more commonly in females. It appears as a flat blue, brown or black pigmentation of the skin. 2/3 of these patients have black patches on ipsilateral sclera and involvement of ipsilateral uvea. 10% can develop glaucoma, 5% can have bilateral involvement, and dermal melanocytosis may undergo malignant transformation, especially in fair-skinned individuals. Uveal melanomas can occur in 0.25% of patients with dermal melanocytosis. Melasma or cloasma is increased skin pigmentation in patches and can affect eyelids as well. In melasma, melanin is found in keratinocytes of epidermis and macrophages of dermis. Melasma or cloasma can occur in pregnant women and women taking OCP following inflammatory dermatosis and as an autosomal dominant trait. Thank you for listening.